Hello.
Hello.
Let's get it.
Welcome back to the Brains and Bones podcast.
Number 2.
Episode number 2.
Yes, sir.
Today we have a very special guest, someone very near and dear to our hearts.
Very.
Dr. Peter Sacci.
Good to be here. Thanks, guys.
Thanks for being here, bro.
Dr. Sacci is a San Diego-based emergency medicine attending physician with fellowship training in ultrasound. To many, he is also a husband, uncle, younger brother, beer enthusiast, and amateur chef.
Just to be clear, not to many, just to one person.
Sorry.
Am I a husband? So just for the record.
Yeah, fair enough. Yeah.
One and only husband. That's good.
Well, thank you so much for joining us. I know we talked about this for a long time,
Yeah.
but it's awesome to have it finally come to fruition.
Yeah, great to be here.
Yeah. How was your shift last night?
It was good. Yeah, it was, probably running on a little bit of a sleep debt, but no, it's good. You get used to it in emergency medicine.
Anything interesting happen?
Actually, so this is kind of funny. I haven't seen, so we'll talk about how we met.
Yes, we will.
Yeah.
But I haven't seen anybody with that particular injury since we last met.
Wow.
And last night I had
wow.
somebody come in with one. So
Interesting.
We'll get into that.
We'll get into that.
We're going to get into that. Okay.
Well, as we're continuing to do on our shows, we like to give our guest a gift.
Yes.
So we have something for you. Not sure if you have any idea what it is.
have some guesses.
Some guesses.
This is for you, sir.
Oh, thank you.
You're very welcome. Very welcome.
Can I open it now?
Yeah.
Yeah, you can.
I like this bag. It's
Brains and
awesome.
Bones bag.
Oh man, these are awesome.
So you can read the card too.
Oh, okay. Perfect. I like this little Sixers emblem on here.
Yeah,
Yes, sir.
So one of my college friends, she's a very talented artist, particularly in the shoe department. And so we want to give each of our guests a little custom piece of art that they can wear every day or once every now and then, or put on their mantle.
That's awesome.
But it kind of has an ode to our show as well as to you. So
Can I read it? Should I read
Yeah,
the card?
sure.
Okay.
Yeah, go for it.
Dear Dr. Sacci, it was a blast making these customs for you. I chose more of an abstract design so you can rock them whether you're in sunny San Diego or back home in Philly. I hope you enjoy them. Alexandria. Thank you, Alexandria.
Yeah.
yeah, so like the outside is San Diego. The swoosh is supposed to mimic the waves of our beaches. The sunshine. We have
awesome.
our brain logo on there.
Oh yeah, here we go on the back.
That's
We've got a Liberty Bell in the back.
That's right.
This is
Initials
awesome.
on it.
Air
Yeah,
Force
these are great.
PS's.
Yeah.
Air Force PS.
These are awesome. Thanks,
Awesome.
guys.
Absolutely, yeah.
Absolutely. We appreciate you being here, and this is a special conversation for us, and so we want to make sure you have something that represents our thanks to you. That's our special item to you, but I know we also talked about you bringing some special items in that you can share with us about your work, and now would be the time to do that. Let's see what you brought.
Cool. So I was trying to think of something that kind of embodied emergency medicine a little bit. So I bought basically tubes with balloons, which is like an emergency department thing. So, the first thing I have is what's called an endotracheal tube. So this is like for our sickest patients. So patients who can't breathe on their own, who need life support. So somebody who we are sedating and paralyzing and putting them on a ventilator so that we can support their breathing when they're not able to. So it comes with a stylet that is rigid, and then you use something called a laryngoscope, or you shine a little light, either with a camera or directly looking.
Okay.
And you pass this tube through their vocal cords, and then you inflate a balloon like this, and attach this to the ventilator, and then you're basically breathing for the patient.
Yeah.
In
So
an attempt to save their lives.
That goes down the throat.
Yep, it's like this. Yeah.
That's crazy.
Yeah, and this is this is what we use on the sickest of the sick, the patients who really need it. And then at the other end of the spectrum, I have another tube with a balloon.
Okay.
And this is basically, it's a certain type of extractor, but this is for like the little kid who sticks a bead up their nose, or has something, pee in their ear, or like when
pee in their ear?
Yeah, like a green pea. Yeah.
Got it.
No, if it's liquid, you don't need it.
Okay.
Yeah,
Okay.
like my
green pea.
My
vegetable.
older brother, when he was like 1, put a raisin up his nose, and then by the time he told anybody about it, it had swollen to the size of a grape. So,
oh my God.
But this is something where you basically pass this little tube up past whatever the foreign body is, and you inflate this little balloon, and then you pull it out.
Okay.
And so again, how are you visualizing the obstruction while you're doing
you'll
that?
use like an otoscope with a nasal speculum on it, just so that you have a light so you can see what you're doing, because you don't want to pass this blindly anywhere and hurt somebody. So you can see whatever the object is, and then pass this past whatever the object is, and then like the last time I did it, it was for a 3-year-old with a bead in her nose, and every time I put this in, she started sneezing, and but she was great about it.
Okay.
And I think the reason I like these two is they're just so different in terms of procedures, and you might have these patients, like you might have the patient you're putting on life support, and then the next patient you see is like a little kid with a bead in their nose.
That's wild.
Not super critical, but still an important part about being an ER doctor.
That one's cool. So
Yeah, you want to take this home?
can I?
Yeah, of course.
It wasn't used on anyone, right?
I don't have to bring that back to the hospital. Yeah.
When you said that, does this work on crayons? Like if somebody were to stick up a crayon up their nose.
And you couldn't see it?
Correct.
Oh,
Yeah,
what?
I bet it would.
A crayon.
I feel like you're
crayon?
speaking from
No,
personal
it's not.
experience.
I am,
Okay,
and it's
yeah.
not it's a crayon. Crayola crayon. It's a crayon.
Tomato. It's a
You're gonna say
crayon.
what do you say? A crayon?
Crayon.
Okay.
Anyway.
Anyways, when I think I was like 6 or 7, and my brother was 3 or 4, and I definitely made him shove up a crayon up his nose.
Yeah.
And they got it out with a paper clip.
Oh.
Yeah, I don't know if that's like normal.
It's not what I would do personally, but
this was back in the early 2000s, so
sure,
hopefully medicine.
I haven't tried it though, so
Okay.
maybe next time.
Now you know.
What is the strangest thing you've had to extract using this?
Yeah.
The strangest thing? For this, I'll use it like on boring stuff, like a bead or a little piece of plastic, Lego, but we get all sorts of stuff, like
that.
stuff goes into orifices and patients end up in the ER, so
Okay.
foreign bodies, wherever, but if I have like a patient who has like a cockroach in their ear, I won't use that on it. I'll get it out another way.
A what?
But that's not uncommon.
A cockroach is not
Yeah,
uncommon?
or like any kind of bug, but yeah. Yes.
Listen, no, it's a no for me.
How big are you
I was gonna say.
Yeah, it has to be the small ones. Big ones
Okay.
can't go in there. Yeah.
And okay, does this stuff ever get on you, like when you're extracting said items? or
Never a
creatures?
cockroach, but
Okay.
sure, I've had coworkers who have gotten bed bugs from the hospital. Yeah.
Yeah. Okay.
Yeah.
Well, I wash
Not
my
me personally,
ears.
though.
Listen. Okay, so how do you?
PPE all
yeah,
day.
all day.
All day.
Exactly.
Clean your ears. That's the lesson. Don't
Clean your ears.
Clean your ears. Okay. Well, thank you for sharing those items with us.
Yeah, of course.
Yeah.
That's really cool. I got a little
Take
thing.
that home.
I'm taking that home. Now, this is not. I'm gonna have to. I'll put it in hand sanitizer or something. Okay. Great. Okay. We have some questions for you.
Yeah.
Just as a little bit of an icebreaker, we're gonna play a game of speed questions. Okay. So I have a list of questions here that I'm gonna ask, and you have 30 seconds to answer each one.
Okay.
Okay.
30 seconds.
30 seconds, more or less.
Yeah.
Okay. First question: what's one thing you can't go into the ED without?
There's so many things. Okay. But I would say a cup of coffee.
A cup of coffee.
Well,
okay.
Yeah, but I like to caffeinate on shift.
Okay.
Not like a huge amount, but
How many cups are you drinking a day?
usually just 1 or 2.
Okay.
Yeah.
All right.
So
That's good.
But yeah, I like to be a little caffeinated.
Alert. Just,
yeah.
Okay. As our beer enthusiasts, I have to ask: pale ale or IPA?
IPA.
Ooh. Wrong answer, Peter. But it's okay. It's great. IPA?
Yeah, for sure.
Why?
It's just stinkier, hoppier,
Okay.
more flavor.
I'm
Yeah.
a pale ale person. I can't.
What's
stand
your go-to
IPAs.
pale ale, would you say?
I don't think I have one. I don't really drink beer that much, but in general, I need something that's less
a little
hoppy.
lighter.
I don't want to be hoppy.
Yeah, that's fair.
Do you,
I don't like beer.
Okay, see, okay. All right, next question is, what is the like funniest moment that you've had in your training in the ED, where you were like, that was very silly of me, or like,
me.
Yeah.
Or not of you.
Ooh.
Or it could, yeah, maybe whatever comes to mind.
Yeah. The funniest thing, that's one I might have to think about.
Okay.
The ER has all sorts of like funny moments, you know, it's like, because everything happens at random, you know, nothing's expected, you know.
Sure.
You come in for your day, you know that you're going to be, you know, there from X time to whatever, but who knows what's going to come in, who knows who you're going to be on with, you know, the personalities that are going to you know, be there. It's not like, oh, I'm in clinic, I know who my nurse is, my MA, my patient, you know, it's all new. So I'll have to think about that one.
Okay, that's fair.
Yeah.
Or I have one.
Yeah.
Any creepy moments, like any ghost stories in the ED?
Oh, yeah.
Yeah?
You asked me about ghost stories before. Do you have a thing for ghosts or about ghosts? Okay.
Yes.
All right.
Yes.
Do you believe ghosts are real?
Yeah, for sure.
Yeah.
But I'd say, I like to think that ER ghosts are like good ghosts.
Good ghosts?
You know?
I hope so, because, we need good ghost energy in the ER.
Yeah.
Okay.
Yeah, I would say something weird about the ER is that the lights never get turned off, you know, because it's always, you know, always open. So I feel like that's like a ghost kind of deterrent, but if the lights ever get turned off, I don't know, like who knows what's going to happen, because the lights are always on. Something to think about.
For the ghost hunters out there, if you see an ER with their lights off, that's your opportunity. Next question. Longest shift you've ever been on in the ED?
So in the ED, we, you know, most places have you cap out at 12 hours.
Yeah.
But in residency, you like rotate through a lot of different, you know, departments. So we, you know, most places do like, or most specialties end up doing an ICU rotation. And those are capped at 28 hours. So you're not allowed to, that's an ACGME rule that you're not allowed to work more than that.
More than
28 hours in a row. So that would be my longest. Yeah.
Okay.
So how many cups of coffee did that one take?
I was going to say,
yeah. Still just one. No, that was probably like 12 or something.
Yeah.
Okay. And last one, what is your favorite thing about being in San Diego area?
Ooh, that's a great question. I would say, I mean, the weather is just like impossible to beat.
That's right. Yep.
So I'd say like, basically like the being able to be outdoors all the time.
Yeah.
Like that's something I kind of miss the East Coast seasons a little bit, but really just being able to be outside all the time. It's December, you're walking around, it's like 60 degrees, sunny.
Yeah.
You don't really have to think about the weather so much. It's awesome.
Yeah.
Good.
That's awesome.
That was it for our speed rounds. I think we went over 30 seconds.
Yeah, I think
on
so
a few
too.
of them,
That's
but
okay.
I think that was our fault.
What brought you to medicine? Let's like walk us through, you know, your life up until training into that main story.
Yeah. So I'd say, I mean, I didn't grow up always knowing I wanted to be a doctor. So I always liked science, and I figured I wanted to do something that kind of had like some interpersonal aspect to it, or like working with people in general, which you know every job has to do to some degree. But I was a chemistry major in college, and then at some point in college, I kind of decided I wanted to go into medicine. So so I took a year off after graduating, just to that was my like application year, and this was all in Philadelphia, where I did my college and then med school and residency.
Shout out Philly.
But I wasn't really sure what field I wanted to go into. I feel like I was interested in a lot of different stuff. Like I remember meeting with my advisor in med school, and my like list of possible specialties was like it was like I kind of like family medicine, but I like emergency medicine, also maybe surgery. Yeah. And she was like, I don't know what to do with you, you know. Like, so
at what point during med school was that?
This was first year.
Okay.
Oh wow.
Yeah.
Okay.
I mean, there are so many people that have no idea what they want to go into.
Yeah.
Or, like when they come in, that's totally okay.
Yeah.
You know?
Yeah, and I think she gave the same advice that a lot of people get in med school early on, just like as much as you can, try to like spend some time in the hospital, you know, just like shadow different specialties. So I like would go to like family medicine clinic or work shifts in the ER or like go to the OR just to see surgery, just to kind of see what would your life look like if you were in that field. And I think if I could go back, I would probably just try to do more of that and maybe even shadow a radiologist, because I ended up doing an ultrasound fellowship because I liked that portion, but just trying to see more things that you would like never consider, just because there's so many things you can't get exposed to because there's too many specialties, so you're not going to be able to see everything on a rotation.
That's interesting. So I feel like that's really good advice, especially for a lot of our listeners who are in med school or planning to go into med school. It sounds like I'm hearing you say, like, especially early on when you're not necessarily dead set on one thing, and even if you are, like, go and get that experience either in clinic or in the OR. Yeah, definitely. Just because it breaks up like the preclinical stuff so much, when you're in class all day long, you probably get tired of being in class, and like it feels like actually being a doctor is so far away. But going to the putting on scrubs, going to the hospital, or like putting on your white coat and like actually seeing patients is so nice, even as a first or second year. So I definitely advocate for, if there's something you're really interested in, then like trying to think outside the box and see if there's other things out there that might actually pique your interest. Yeah, for sure. That's awesome. Okay.
So at what point did you come to that conclusion of what you wanted to do?
Yeah, I think, so I'm an emergency doctor, so we do a little bit of everything. I think just like thinking about what my day would look like if, and not to like knock any other specialty, but certain specialties do very similar things during the, every day, either the same procedure or even if you're like in clinic, you're seeing different things, but your schedule is kind of regimented. And I just like the diversity. I like the fact of emergency medicine, when you're on, and when you're off, you're off. So when I'm at work, I'm 100% there, like all in, no lunch breaks, nothing like that. But when I'm off, and that time is my own, and I like that. And emergency medicine kind of fit into that, wanting to be the most intense while I'm at work and not having to take call when I'm, supposedly off, while also being able to see a diverse range of things. So like third year, going through every rotation and liking a little bit of everything, it kind of made me realize that I wanted to do something that had like some procedural component, but also like sitting with patients and taking histories and talking to families, and having kind of like the device that you got in your hand, just like some kind of like more like really small, like little things that are not that intense, and also things that are intense. Like I liked little components of every rotation, so I thought EM was the right field for me.
Yeah,
that's dope.
So third year, I would say.
Third year. Okay. That's cool. So when all of your training you were doing in Philadelphia, and just because we got to shout out some pride, where did you go for college?
So I went to Haverford College.
Haverford College.
It's a small liberal arts college. It's just outside Philly. It's like 1,200 students.
I actually believe we have a classmate who also went to Haverford.
Oh, yeah?
Nice. Yeah, so very familiar.
Cool.
And then where did you go for medical school?
I went to Jefferson, which is in Philly, downtown Philly.
So then from, third year, you kind of get this feeling, all right, I'm going to go, I think I want to do emergency medicine. How do you go from Philly to landing here? Yeah, so I did my medical training in Philly, and then after residency, depending on what field you're in, so if you go med school, then everybody has to do a residency, and then depending on what field you're in, there's different fellowships that are available to you. So for emergency medicine, there's something called emergency ultrasound, which is different than like radiology ultrasound, but the same technology, but kind of its own field. Got it.
So I became interested in that in residency, and did a fellowship out here in San Diego in emergency ultrasound.
And couldn't leave from there.
Yeah, I got stuck.
Yeah.
Yeah.
I feel like a lot of people do.
I mean, I was gonna like.
We're not from, but we see that.
Yeah. I mean, I thought I was gonna be here for like a year. Moved out here with my wife. She had a fellowship as well, and we thought we'd be like here for a year and then be somewhere else. And it's just it's hard to leave San Diego.
Yeah,
it is.
That's awesome.
Yeah.
walk us through residency and all that unfolded.
Yeah, so I did medical school in Philly at Jefferson, like we said, and then we wanted to stay in Philadelphia for residency. So for residency, you go through something called the match, where you decide what program or what specialty you want to be in, and then apply to a bunch of programs and interview at those, and then kind of you make a list of which programs you are interested in.
And just for perspective, because we hear a bunch and we're like, oh, okay, a lot. Can you let us know, like, how many? What was that process like?
Yeah, and I'll say it's definitely changed since COVID. So because interviews are virtual.
Yep.
So I know, like, now there's a little bit of controversy in medicine about basically people applying to too many programs. So I think, and this was a few years ago, so I want to say I maybe applied to like maybe 30 for emergency medicine, and then maybe I interviewed in like the low double digits is what I honestly don't remember, but but basically just like, and different specialties are going to be like, some are very selective and some are less selective. When I applied, emergency medicine ended up like filling 100% of their slots. So, and it's changed a little bit. But yeah, basically, so like for residency, when you're applying to residency, you rank your programs, and then programs will rank you, and then this algorithm kind of matches programs with applicants. So we knew we wanted to be in Philly. So Philly, fortunately, has a lot of emergency medicine programs. So so that was a benefit, and I matched at Hahnemann Hospital, which is like an older, it was Hahnemann University Hospital, so like a university hospital, so lots of specialties, subspecialties, but in terms of the population that it saw, kind of similarities with like a county hospital, but affiliated with Drexel Medical School. But yeah, I was excited to end up there for residency. And then, the hospital had been around for maybe 170 years, I think.
Wow,
so I've been around for a while.
It's a long time.
And in like the early 2000s, had actually came under private ownership.
Okay.
Who was it owned by before it came under private ownership?
So I think it was, I'm honestly not sure, but I think it was just like through the unit. So there was a Hahnemann University.
Okay,
and then, and I don't want to, I'm sure I'm missing some of the timeline here because it was before my time, but Hahnemann University merged with Medical College of Pennsylvania, which was like one of the first emergency medicine programs. So there's like a merger, and then they came under the umbrella of Drexel for the medical school side.
Okay.
But the physical hospital was owned by a series of private entities. Okay. So came under private ownership and had always been in kind of financial trouble, and that was like a well-known thing, in Philadelphia, but the idea of a hospital actually ever closing, especially a hospital that large, was unheard of. So, when I was applying for residency, it was something that, I knew about, but didn't actually think would ever, thought the hospital would ever close. Just because, when you've been hearing about something for years, you just don't really think it's ever gonna really happen. And everybody you talk to says that hospital's been around forever. They would never actually close the doors, But when I was late second year, so it was late June of my second year, right before my third year, they announced that they were going to, and it had been bought by a single person, so it was owned by one person, and that person announced that they were going to close the hospital.
Wow.
And then 2 months later, the hospital was closed, lights off, doors locked.
Why?
Yeah. So, yeah, it's a good question. I mean, you could argue that basically the short of it is that the hospital was not profitable. So you could argue that maybe, should hospitals be profitable? What is the point of healthcare? Is it to make money? Is it to serve people? Is it to do both? Is it, is it a business? Is it, like a money-making opportunity? Is healthcare a
Sure.
human right? Is it, there's a lot that goes into that. I would say, like, personally, like having, private equity or, involved in healthcare, I think is dangerous. Because then, where's the focus? If you open up an ice cream shop and like your focus is making ice cream, but it's making money, that's one thing. But when you have people's lives, in your hands, then you could argue that maybe profit or money, it's important, and you need to have like money is a reality of life. But once people are investing their own money in a hospital and expect to get a return,
right,
then the focus does shift away from patient care. And there's all sorts of evidence that like there's a study published in JAMA in December of last year about how mortality rates at hospitals owned by private equity firms are much higher than ones that are not.
Wow.
How catheter-associated infections are higher. Just because, when you're at a hospital where money is a big focus, then corners are just naturally going to get cut, and the focus just shifts away from patients.
Yeah, you're detracted from providing quality health care.
Yeah.
Competing priorities.
Right.
Yeah. So I'm kind of curious because, like, how does one announce that they're shutting down a hospital? Like, how did you hear about it? Was it an email? Did we gather all of the staff together? Like, what was that like? Yeah.
So I was in ACLS, or Advanced Cardiac Life Support, is like a class that everybody or like residents or nurses have to take, just about like CPR and defibrillation. And anyway, I was doing my recertification for that with my co-residents. And one of them, we knew that there was like a meeting that was going on about like the future of the hospital, and it seemed kind of like almost like a steering committee meeting, like where do we need to go? Do we need to tighten our belt? Do we need to do this or that or expand this but I got a tap on my shoulder from my best friend in residency who was sitting behind me, and he had the 6ABC story that had just broken.
No way.
So it was, via the news.
Wow.
And then our department chair brought us all together and like announced it later that day. But yes,
that's insane.
It was the news.
How big was that hospital?
Yeah, so it was almost 600 residents and fellows. So it was like 570 residents and fellows. So, and then in terms of doctors, attending physicians, I'm not sure, but
that's a pretty
maybe
sizable
1,000.
hospital.
I don't know.
That's
but yeah, big.
wow.
And then the affiliation with the medical students, and then there's the physicians, and then the rest of the medical staff, and then it was a huge employer for our techs, our patient transport, security, registration. It was just a
lot of people involved.
Yeah, it was a lot of people who all of a sudden found that they were losing their jobs
through the news.
Yeah.
That's crazy.
Can you
wow.
Walk us through?
We did get an email later that day.
But incredible how you first heard it on the news.
Yeah.
Like you would expect, I don't know, some common decency.
Email and then article.
Yeah. Even just an email.
Yeah, and I think I'm sure it's hard to, when you're going to announce something big like this, to because it was kept very close to the. There was an inner circle of people who knew, and even our like department chair, who had a lot of clout within the hospital, didn't know until that point. So it was kind of announced to the world at large, and I think the closure, because it was going to be very controversial, I'm sure that they were taking a clear systematic approach to it, and to how do you break the news and alert the state health board, and there are all these kind of hoops you have to jump through when you're going to do something this this scale.
Yeah, that's incredible.
Yeah.
I know this obviously impacted you, other staff members, co-residents, but it also affected the community at large. Like, I want to hear about both, but like, walk us through the community that hospital served.
Yeah, so the hospital is in downtown Philadelphia, which is like kind of a big mix. There's like high rises, fancy condos, fancy buildings, and then It was kind of right on the border of Center City and North Philly, which is there's kind of a pretty abrupt change, I would say, from like condos with lots of money, or areas with a lot of money, and then areas with less money. So the population, it was again a mix, but a large number of patients who were experiencing homelessness, large number of like a decent immigrant population, and then a large number of Black and brown patients from the community like North Philadelphia and Center City. Because it was downtown, you would also get like, a decent tourist volume. Is right next to the convention center, like in the 70s or 80s, whenever Gerald Ford was president. He had a stroke and was seen at this hospital.
Oh, wow.
So it's kind of like, it was an interesting mix.
Yeah.
But a large, and probably a reason why why the hospital wasn't making a lot of money for the people who owned it, was because the patient population there wasn't a lot of money, people without, who were either uninsured or underinsured, receiving kind of acute care there.
So the people who need the most help, that's who you guys saw.
Yeah, and that's, my perspective is a little different because in the emergency department you kind of see whoever comes in, but that population was definitely overall sicker, with fewer resources, definitely a population that needed a hospital there.
Wow. When you heard the news, or like you first see it, like what were the first things that came to mind? Like what is the initial reaction?
Yeah, I mean, or at least my initial reaction was kind of the self-centered one of like, what happens to me, and what do I do
for sure
next?
Yeah.
So we got the news, and then the first thing I did was I called my wife, just because I guess we were going to get married in like a month, but it was kind of like but it was like what here, this is something that's happening, and I don't know what that means. Like, as a resident, you have to complete training before you can get a job.
Right.
So what does that look like? Like, if the hospital closes, do I apply next year? Do I reapply? And there had been residency closures, but nothing of this scale. So the first thought is kind of, where do I fit into this puzzle?
Sure.
And fortunately, again, I would say our faculty was really helpful, our chair, and then the other hospitals around Philadelphia. So there's there's something like, maybe there's like 6 med schools in Philly, and then associated hospitals, and then some hospitals that don't have an affiliated, are affiliated with medical school but don't have their own. But there's like, in the greater Philly area, maybe like 10 emergency medicine programs.
Wow. Okay.
Do they have space though? Because it's like you have an entire program, and not just emergency medicine, but the entire hospital of programs and physicians. Like even the chair, like what does the chair do?
Right.
Like, do the other hospitals have space?
Right. So emergency medicine, again, I was in a little bit of a fortunate position, because this hospital that was seeing something like 60 or 70,000 emergency department visits a year is going to close. And the surrounding hospitals kind of do some quick math and realize that they're about to get a huge bolus, a huge influx of patients. So emergency medicine, once I left Hahnemann, I went to Jefferson to finish my residency.
And back home.
Yeah, exactly. And the program director there did a huge amount of work at Jefferson, actually, to kind of see what she could do to help place emergency medicine residents from Hahnemann. So she arranged kind of like speed dating with program directors in the area.
Oh, wow.
To come and basically interview residents who are about to be orphaned from EM, and just to kind of see who could match up with which program.
Okay.
How long did it all take? Like, what's the gap of time?
Yeah. So we found out end of June, and then the hospital ended up closing, I think, like August 5th or August 6th, something like that.
That's insane.
Wow.
So
2 months.
Yeah. So it was like, it ended up being like 6 weeks. The medical board in Pennsylvania has like a rule about like a 90-day announcement if you're going to close a healthcare facility. And then they didn't quite make it. Yeah.
Wow.
So it was quick turnaround time, but I would say there were a lot of stakeholders within the medical field who put in a huge amount of work.
That's incredible.
But EM was lucky. Some specialties were not so lucky. So like our, I'm not going to say specific specialties, but certain residents were basically, there were hospitals or systems that didn't need more residents. So those residents had to go to other cities and states. And then if you're, if you are on a work visa from another country, it's illegal for you to be unemployed. So if you're on, if you're, did medical school at another country and you're not a U.S. citizen and you're on I think it's a J1 work visa, you can't be unemployed or else it's illegal for you to be in the country. So for me, huge deal if I don't have a job, but my timeline gets delayed, I won't literally get deported from the country where me, my family, my kids are currently living.
Wow.
So for a lot of people, it was a lot more stressful than it was for me.
Do you have any friends of yours that were in that situation?
So there were a couple of our residents two of our residents who did emergency medicine training in the Middle East, then did toxicology fellowships at our hospital, and then to be eligible for boards in the U.S., had to repeat a emergency medicine residency. So they'd already done residency training in emergency medicine at amazing hospitals, and then done toxicology fellowship. So they were the best residents ever. They were already attendings, but were repeating residency. Unfortunately, they ended up, getting residency spots, so they ended up okay. But scary, for this is your home now, and all of a sudden, this unforeseen event, and your visa might not be valid anymore.
Wow. Yeah. And the rest of the medical staff that helps run the hospital, what do they do?
Yeah, so you have these faculty members who have been at this hospital for decades, and they, certain people retired, certain people moved hospitals, and some moved within Philly. So some of our faculty moved to other hospitals in Philadelphia, and then some moved very far away. But if you're a physician, one nice thing about being a physician is that there is some element of job security. So,
so long as you finish your training.
Yes, they don't want 2/3 of it either. But people were able to find jobs. But you may have built an academic career at this, institution, and then all of a sudden, you have to pick up and start over somewhere else, which is obviously really hard for them.
What do you think you would have done had the other program in the area not come together to help solve this issue? Because I feel like this is a very unique case where they took that head on, owned that themselves. It was not their problem. They owned it and did what they could to help. But let's say that didn't happen.
They didn't have to.
They didn't have to.
Yeah.
No, they didn't. So one thing for anybody listening or watching who hopefully nobody ever has to go through this. But if you are an orphaned resident, which is what they called us.
That's a term,
you are an orphaned resident.
Wow.
So when you're in residency, your paycheck, your funding, comes from CMS. So it comes from the federal government.
I did not know that.
I did not know that. Okay, all right.
So
and that's every specialty?
Yes.
Okay.
So our, basically, tax dollars pay for training our next generation of physicians. One benefit of that in my case, or in our case, was that your funding is attached to you, and you may be committed to this hospital, but if that hospital closes, you still have your X number of years left of funding.
Got it.
So one thing, let's say you just can't say you match somewhere where you don't want to be. You can't just call up any other program and be like, hey, I have funding, can I move to your program? But if you're orphaned, then you can reach out to other programs, which people who, a couple of our residents wanted to end up on the West Coast eventually. They're like, well, I guess I'll just do it a year early. So they reached out to programs on the West Coast.
Got it.
As long as they're approved by the department and the hospital, then their funding transfers. So the hospital that you want to start or restart your training at doesn't have to come up with your salary.
Interesting.
Yeah. So it's fixed to you. So if you end up at a program that closes, then you will still have funding. That was a big concern that I had because I didn't know how the system really worked.
Yeah, this might be a bad analogy, but it kind of reminds me of like in the NBA when like you're trading players, but they come with a guaranteed salary, like you have to pay them. Not that you're exchanging, but it's like you come with a package of money already set, which is interesting. Wow, okay.
That's a good analogy.
Was it good? Okay.
Yeah.
Thank you.
Yeah.
I was gonna ask in that time, what did you see? Like, I mean, you're from Philly, born and raised.
I'm from Baltimore.
From Baltimore,
but I've been in Philly
Baltimore.
So I grew up there.
Okay.
Yeah, but then have been in Philly lived there for maybe 15 years. So I've been there for a while.
For a while.
Yeah.
You have community there.
Yeah.
And you're training at a hospital in the city. Was there any sense of like, what happens to my community now? Or the people that, I can imagine in situations like that, you might have people that you're seeing in the ER more frequently or whatnot, and what happens to them or things like that. Can you walk me through your thought process with that?
Yeah, I mean, there's a big subset of people who really depended on that emergency department for food or a dry place to sleep, and you could definitely argue that like an ER is not a good place to like house people, right?
Sure.
But it was a social net hospital. So, people who were either unhoused or unstably housed or didn't have good access to food, that was a place where people could get a sandwich, and sit in the waiting room overnight if it was snowing outside or raining or something like that.
And hospitals are safe havens.
Yeah, they are. Yeah. And then there are also just like, there's a large group of patients, like patients who had their renal transplant at this hospital, or patients with, a chronic condition. Yeah. Their cardiologist was at this hospital. Let's say they have poorly managed CHF or hard to control CHF and maybe don't have good access to their medications or healthy food. So patients who are repeatedly coming to the hospital for exacerbations of their chronic conditions.
Got it.
But they were known, you can see their records, now EMR or electronic medical records are a little bit better and more integrated, but not everywhere talks to everywhere else. So all of a sudden there's these patients who have, a 20-year history getting seen at this hospital, a lot of history there, and then all of a sudden they have to go to a different hospital who, maybe is not able to look up their records, or like some patients might feel uncomfortable going to a new hospital.
Sure, yeah.
A different, if they have to go to a different academic center, it can be intimidating. It's like going to a new school. So for the patients, they're used to getting their care at the same place, and it was a trauma center. So there's like a story a month after the hospital closed about somebody
trauma center too. Wow.
Had they got shot. They had a gunshot wound, and basically walked to the hospital because it was like around the block, and then the hospital's closed. So, it's just like a fixture of that community. It was right on the subway. It was like relatively easy to get to, and all of a sudden that's not there. So it's patients who have been going there for years, but also just people who know about this hospital that all of a sudden is no longer there.
Damn. That's heavy. I'm sorry. Yeah. Wow.
So did you guys see any trends within like the patient population? Like what happened to all these patients post all this happening?
Yeah. From a population level, I'm honestly not sure. Philly is, like a lot of cities, it's kind of like siloed. So the catchment area for each hospital If you're like a major academic center and you have a huge referral network, you may be getting patients from all over the world. But if you're a safety net, hospital, you may only be getting patients from like a smaller geographic area.
Yeah.
But when Hahnemann closed, all of those patients had to go somewhere, and the demographics at various emergency departments definitely changed. Volumes obviously changed. So from an ER perspective, there's definitely a big change at Jefferson, where I ended up. From a trauma perspective, like the sicker cardiac patients, and that was an overnight change. Like trauma volume was overnight. As soon as Hahnemann closed, trauma volume at Jefferson significantly rose. And then, this was in 2019, so I don't know if you remember March of 2020, if anything happened, but...
I remember I was planning on going on a spring break trip with my friends to Hawaii, and we were like, maybe we shouldn't go. And then definitely couldn't go.
Or you go and you get stuck.
And you go and get stuck, but that wouldn't... it would have been a very expensive, long vacation. Maybe it would have been cheaper, though.
You would have figured it out.
Yeah, anyway.
But
please.
So, the pandemic was really hard on everybody globally.
So this is while you're still in residency?
Yeah, so I was a third year. So this was about 6 months after Hahnemann closed. It was like March of 2020.
Wow.
So now all of a sudden you have, hospital volumes went down because people were kind of locked down, and people maybe were going to the hospital less for things that weren't true emergencies.
Sure.
But the true emergencies were real emergencies. Hospital, from a critical care standpoint, there are a lot of very sick patients going to hospitals, and I would argue that having another large hospital would have been very helpful for the city.
Yeah.
Because now all of a sudden hospitals are having to absorb a lot of really sick patients.
Yeah.
And I'm sure you saw stories from New York, and Philly was similar, but about hospitals that had to get refrigerator trucks because their morgues were full. And it was an emerging disease that we know a lot more about now, but at the time, didn't know a huge amount about. There was no vaccine.
Yeah.
So patients were getting sick, and they were getting really sick, and then patients were dying. And Philadelphia was definitely hit very hard.
So just to summarize this, you're in training in Philly. The hospital that you're at closes down just 6 months before a pandemic that took the world by storm, and you're a third-year resident at this point.
Yeah.
That's a lot in a very short period of time. And I think one of the things that, we're learning in our training now is making sure that we build resiliency. Things like that can happen, right? Life doesn't follow any script that we know. How did you stay sane? What was your mental and if you can share a little bit about, what you did to remain resilient in those times.
Yeah. I mean, one of the things I really like about emergency medicine is that it's, everything's really compact and tight. When you're working, you're in the, sitting next to maybe your residents or med students or nurses or tech, everybody's kind of together. And, you call your attendings by their first names, you're, in some ways it's hard to gain independence because there's always the team's always all there. You're never by yourself doing your own thing.
Yeah.
There's always a big team there. But I did feel there was this kind of team mentality in the emergency department through COVID as well, where you might be a resident and your attending doesn't know any more than you do about COVID because we just figured this out that it existed, but there's this kind of feeling of trying to really figure it out together. And that felt, it made it a lot more tolerable. Our schedules were changing every day based on need. Our protocols were changing. One thing was, if a patient has COVID and they need to be intubated, then the best intubator, the best person to actually put the tube in should be the only person in the room doing it, and then one nurse who's pushing meds. And that might be, if your attending has been an academic attending for a while and maybe has just been teaching and hasn't been doing procedures themselves, as the third year, you might be the best at doing this procedure.
Yeah.
So for a while, you know, like it might be like the resident and the nurse in the room with the really sick patient, and the attending might actually just be outside. So you're kind of like, and that might be the protocol. Or the protocol might be, oh, it's just the attending taking care of the patient. You know, and things were changing. We were giving like, you know, different medicines, like that. Maybe there's one paper that, oh, this medicine might help, you know, like giving hydroxychloroquine or like azithromycin, you know, and then the next day it comes out and like, oh, that actually doesn't work, and maybe it makes them worse. Or giving a lot of fluid is helpful, or, you know, giving a lot of fluid is bad. You know, how do we prevent these patients from needing dialysis? You know, everything's evolving constantly. But there was this kind of like understanding that everybody's like really just trying their best, and everybody really was trying their best. So I think when you see somebody you respect, like an attending, somebody who's gone through training, even if they haven't gone through like a global pandemic like this before, when you see somebody you respect kind of like really in the trenches with you, that goes such a long way. And I definitely benefited from that. And that, I think, you know, things just feel a little bit better when like, you know, somebody else is really trying hard and they're struggling, but they're like, you're all just trying to figure it out together. I think resiliency is a lot about like looking around you and seeing like, who can I try to emulate? Like, whose energy can I try to emulate? So I think just like that kind of communal mentality was really helpful. It also helped that I got COVID in March of 2020. So I'd already had it, so I was like, I'm good. Like, this means I'm immune forever. We thought it.
Oh my,
But,
wow.
And that was definitely scary. Just not knowing, like, and that was when like we were sending tests out. They were taking like 5 or 6 days to come back. So you like, you know, I had fever, cough, you know, shortness of breath, lost my sense of taste and smell. But by the time the test came back, it was like, oh, you have COVID. You're like, oh, I feel better now. You know, it's fine. So, so I was fortunate. But
and remember, because I know the hospital closed down about a month before you were planning to get married.
Yes.
Right? So then what happened with that?
I got married. But so I moved training sites to Jefferson, and my program director was very understanding of the fact that, like, you know, I needed to be off for October 19th. So we, you know, and we were getting married in Philadelphia, so you know, we didn't have to change too much about that. But yeah, fortunately, Jefferson was very understanding about the fact that we like had lives, or like there were 12 of us that moved over from our residency. So the transition was actually as smooth, I think, as it could have been. New hospital, you know, but a lot of the same patients, because they moved 6 blocks down.
Really quick, I want to go back a second, because I think this is so important. This is like really touching on equity. You know, so many patients who your hospital is seeing lost their safety net, blink of an eye, you know? And like you're mentioning, there are so many people who had long-standing chronic conditions that are being managed for so much time. Patients who have, you know, no health insurance, this is the only place where they can go for acute care, even long-term care. And like from what it sounds like, you guys were left in the dark till this happened, and they had no idea it was happening either. So it's like, I'm trying to figure out my question, but it's like, it's frustrating that that happened, and like, what do you think could have been done better? And like, if this were to happen for whatever reason it might have been, right? The hospital has no money, and they have no money to actually put towards healthcare. Like, sure, if we have no money, we can't actually help these patients. But what do you think they should have done in either, you know, telling everyone this is happening so we can better inform the patient population that, hey, we'll no longer be able to provide care to you. Here's what you guys need to do going forward. You know, like, what should they have done better? Yeah, it's a hard question to answer. I'm sure a lot of things could have been done very differently. You know, for patients who had long-term physicians, either as primary docs or their specialists, I'm sure that there was some kind of conversation between those individual physicians. But if you have a physician who like
decides they want to move or retire, you do have patients who are kind of left in the lurch and they have to find a new specialist, which is hard, especially, if your health literacy is really good, you can try to figure it out. I think insurance is really complicated. I really struggle with figuring out insurance for myself personally, but also for a patient. How does that kind of affect things? And I'm a doctor, and I've been doing this for a little while. For patients who maybe didn't graduate high school, maybe don't really understand their disease process all that well, are struggling with poverty or addiction, or are working 8 jobs just to kind of make ends meet. I don't understand how you could ever manage chronic conditions. So for those patients, again, fortunately, Philly does have a lot of hospitals that are close with a lot of specialists. So if you needed emergent care, there's another hospital down the street that would be overwhelmed with the patient, the influx. But for those patients who had a specialist that they really liked
and trusted,
that's such an impossible position for them to be in, especially if you're already managing a really hard to manage disease. If you already, even with the stability of your same doctor, if you're already struggling to take your medications on time and eat the right foods and make your appointments just because of life things. I don't know how you do it when your doctor changes or disappears, or the hospital you've been going to for years is gone.
It's an impossible situation.
Impossible situation is right.
I
was gonna say, in going from the first institution to the second, was there any period of transition or struggle to get used to a new system? Was it a new system? What was that like for you?
Yeah. So the dates I'm a little hazy on, but I think it was August 4th. I was a Hahnemann resident. August 5th, I was a Jefferson resident. Yep. So next day.
Wow.
So you can't have a gap in your training for credentialing, or for accreditation and boarding purposes. So that's been an issue, getting boarded, just because it is confusing. Why I was at one hospital for 2 years and 2 months, and one hospital for 10 months. So the California Medical Board, I've definitely confused them. But for my own transition to Jefferson, I had the benefit of being a med student there. So I was there for 4 years. So it'd be if you guys leave UCSD after 4 years and then end up coming back, you're going to know where the bathrooms are. You're going to know Jefferson is it's a super old hospital. So lots of different buildings of various ages. So there's tunnels under the street, that I remember from being a med student, and the sky bridges, and which elevators are really slow and which ones are fast, that kind of stuff that was helpful. But for my co-residents who maybe hadn't rotated there or never been there, it was a big adjustment. And especially for the third years, if you're, third year, you're running the emergency department, and you go from being at one hospital where, you're running the ER, that's fine. And then a new hospital where you're working under an attending who doesn't know you. They don't have the benefit of having watched you grow for the past 2 years. So it's a really hard position for them to be in. They don't know if they can trust you. And as the resident, you're trying to learn all the nurses' names, where everything is, trying to learn the attendings and their style. So for me, it was a big transition, but for my co-residents, they definitely they had to work much harder, even just to learn where everything was physically. But I think everybody settled in pretty well.
Cool.
And then the year below me, and then the year below that, actually 2 of our residents that moved from Hahnemann to Jefferson ended up being chief resident. So they settled in nicely and did really well as chiefs. So
very cool.
I think people made it work. That's a big thing about the emergency department is and just medicine in general, you kind of have to figure things out on the fly, because you might be dealing with something you've never seen this way before. And you still need to figure out how to make it work. And I think, I think our residents did a really good job, the residents transitioning, and then the residents at Jefferson they were great at welcoming us. I think the attendings there did a great job. I think people really, really, above all else, just wanted this to work.
Absolutely.
That's awesome.
And I think that was a cool thing about the medical community. Just like above all, they just really wanted like people to get taken care of, the patients, the transitioning residents, the new attendings. I think everybody just was really motivated, and it could have been way worse. But it was nice that everybody just like the top priority was the same for everybody, just trying to get through this. And
it really is amazing to hear how the entire city, all the programs kind of came together to make it work for everyone involved, not just the patients, but you guys and everyone who came out from that tragedy were taken care of, which is pretty amazing.
Yeah. And emergency medicine is like, it's one of the shorter residency programs. So, 3 years or 4 years, depending on where you go. But for people who are like in their 5th year of their orthopedics residency, or like, at the end of their surgical residency, and then all of a sudden they just have to like power through 10 months, but they're like a senior resident. So they're supposed to be like operating independently, like it was hard for everybody. I think we had emergency medicine, we were fortunate in ways that some other specialties weren't. And everybody like, people were able to land on their feet, but imagine like getting to know your OR staff for the past 5 years and all your attendings, and then all of a sudden you have a new staff and they really have to trust you that you know what you're doing. And so I think harder for other specialties for sure.
I think it's really cool and admirable when I hear you talking about this experience, in that like, as crazy as it was for you, you still have perspective to think about other people who are also going through the experience, namely the community or other people training. And like, I don't know anybody who didn't have it bad in that situation, but for you to be like, I think these people had it worse. I just think that's big of you to just have that perspective, for real.
It's not, it's because I ended up okay. Maybe if something had happened differently, I would have been like, oh, I had it the worst. Everybody else had it easy, But for being such an awful experience for everybody involved, it is like it's a little bit weird to like look back and be like, oh, it's all in the past. Like this was a big thing that happened. And when I go back to Philly, like the lettering, the building's still there. The lettering is all off the side. But it's still kind of it's surreal. That this happened. And it makes you think like, could this happen again to somewhere else? 100%, It probably will. Not to scare you, but.
Well, I think your story, you sharing your story and letting us, hear about your experience, hopefully it doesn't happen again. First of all, there's no wood to knock on, but, but I think that's part of the reason why we really wanted you to share your story, because when crises happen like this, like, it's important to know how are people dealing with it, what was it like, and at the very least, more people are aware now, and our listeners get to know that this is something that can happen, and hear somebody who went through it, and thankfully you are okay. Still working out, and helping. But I think that's big.
More people know that, maybe private equity in hospitals isn't.
There's a lot to unpack there. And there's a lot of literature on basically on private equity in hospitals. There's a lot of stuff that's been published about Hahnemann specifically, and then kind of emerging groups kind of involved in private equity. So I think there's a lot for your watchers and listeners to read about or look into,
to be informed.
Because I think, it's probably not going to go away. It's just kind of like, if you're interested in medicine, how will that affect where you decide to train, where you decide to work, like what kind of group, what type of job you want to have after you're done training. And those are things that I never really thought I would have to consider as a resident, and are things that I think about a lot now, and then would definitely it's another layer of like what to consider in medicine in your career. It's kind of like what type of training do I want to do? What's the place going to look like? And then where am I going to work afterwards?
Sure.
That's good.
Yeah, I know we've been talking a lot.
But
like, you really before we wrap up, walk us through what you're doing now in San Diego and how, your work looks now.
Yeah, I would say I have a really great job here. So it's kind of like it's a great mix in emergency medicine. So I'm working in a kind of like a hybrid emergency department where there are residents and medical students, but I won't have a medical student or resident with me every shift. So, so some shifts I'm kind of by myself doing my thing, which is nice because then I get to do my own procedures and get to, I kind of have the reins for my whole shift. And then some shifts I'll be with a resident. Whereas a supervising attending, something you don't really think about is like you kind of have to learn to let go a little bit. Like I'm definitely not a control freak at all, but when you're like supervising somebody doing a critical procedure, it's nerve-wracking, because it's not your hands, it's
right.
You want to protect the patient and you want to protect your resident and teach them how to do something appropriately, but you need to do it kind of with your hands behind your back most of the time.
Like driving school.
Right.
When they have the emergency brake?
Oh, yeah.
That's what it feels like.
That's what it feels like.
But imagine you're like in the trunk without an emergency brake, and I like to work with the residents just because it's really fun to teach. So right now I work with them in our simulation center and then teaching ultrasound. So I get to do a little bit of everything. Still spend a lot of time in the emergency department just taking care of patients, which I really like. But then the teaching element is really fun as well.
Very cool. Yeah. Very cool. Well, Peter, thank you.
Yeah, thanks for having me.
This has been very eye-opening. We both have learned a lot, and I think, again, this was very much a story that hasn't been heard, and we wanted for it to be told, and we're really appreciative of you taking the time to do that, especially after working an overnight shift. Quite literally, what?
Yeah, I didn't fall asleep, so.
Yeah.
No, happy to be here. One thing I would add is that my perspective is just that, it's a single perspective. So there's a lot, people have written stuff about, there's like a lot of other stuff that I would encourage your listeners and readers to look into, just if they want to learn more. Because I think there's a shared experience for sure, where we all were orphaned, we all had to find somewhere else, but there's a lot of untold stories out there, I'm sure. So absolutely. But this is a great opportunity. Thanks for having me.
This is the Brains and Bones podcast,
of course.
And so one segment that we have to the conversation is mentioning a brain and a bone. And so the brain is, as medical students, what's going on more administratively in the medical education space and in healthcare. And recently, I think just this week, Albert Einstein School of Medicine got a $1 billion donation to make medical tuition free for students as of this upcoming year.
That includes fourth years who are still in school right now as well.
So everybody's,
that's awesome.
So just any thoughts on that?
Yeah, I mean, I think that's amazing. I think, I was fortunate where my loan burden is not as high as a lot of my, co-residents and classmates, but, I still had six figures in medical school loans that I had to take out. And there's so many things that go into like choosing your specialty, but I think one thing that weighs heavily on people is, can I pay back my student loans? And if the one thing preventing you, or one big thing preventing you from going into a specialty that you really want to do is, or maybe you want to work with an underserved population, or in a place that doesn't reimburse at as high a rate, or you want to give away a little bit more healthcare, having to not worry about your, $300,000 in student loans, if that removes that barrier, that's awesome. I would say medical school is expensive. Everybody is able to pay off their medical student debt at some point, medical school debt eventually, but it's something that I think everybody who takes it out really thinks about heavily. So I'm all for removing that as a barrier. And I think only good things can come out of that, for sure.
Absolutely.
Yeah.
Absolutely. And our bone, little piece of information you can take away from this, you probably already know it for our listeners, calcium oxalate renal stones.
Yep.
A type of stone found in the kidney. How do we treat it? Thiazide diuretics.
We're in our renal block right now, and I'm not going to say that I knew that, but now I do.
If you don't know, now you know.
We want to give a special shout out as well to Sanford Institute of Empathy and Compassion for their support of the show. And in that, we like to end every show with a moment of compassion. And so, the question is, can you share an experience or that you've gone through or that you've seen happen where you saw compassion and empathy being implemented?
Yeah, I would say, one great thing about the emergency department is sometimes you get to save somebody's life, which is amazing. Sometimes you don't. And then, sometimes you can give somebody's last moments a little bit, make them more comfortable, kind of help somebody die with dignity. I had a patient, it was a couple weeks ago, but they were on hospice for a lung condition and basically were truly end stage. And they came in, extremely short of breath, very uncomfortable, but they had filled out an advance directive that when they were on hospice, but did not want to be resuscitated. So no CPR, no shocking, no intubation or being put on life support to prolong life artificially. So this person was, dying, and that was their wish, but they were very uncomfortable. One thing that I wanted to do when the patient first came in was I don't want to we put patients on a morphine drip, which helps with something called air hunger, where you're feeling uncomfortable, maybe put on a little bit of oxygen, but basically to help somebody stay comfortable as they're dying. And what I didn't want to, we did that, but I didn't want to jostle the patient too much. They were in their nightgown from home. And so I was talking to the nurse and I was like, let's just kind of leave her. We're not going to bother her. Just help her be comfortable. And this nurse who I've worked with for a few years now, and he's so amazing. He was basically like, thank you, doctor, but let me do my job. This is what I do. My job is, being a nurse and making my patients comfortable. He's like, I really want to change her. I think jostling her a little bit, getting her out of her uncomfortable pants or nightgown, he was basically like, let me do my job for this patient. And that was his way of saying you're good at doing your job, nursing care is what I know. And the patient was so much more comfortable.
Wow.
It was absolutely the right choice. And it was great of him to kind of not put his foot down, but basically be like, we're a team, I'm going to do my portion of this to help my patient, die comfortably.
Wow.
And then 6 hours later she died, but her family was around her. It was a hard moment for them for sure, that they all knew was coming. But I think, in medicine, sometimes you can just make these last moments for patients as compassionate and comfortable for them as possible, and not make somebody's last moments really terrible. I think he did a great job.
Thanks for sharing. Yeah, appreciate you sharing.
Well, thank you so much for joining us.
Yeah, it's
this
been great
afternoon.
To be here. Thanks for having me.
That was an amazing conversation, and again, we truly appreciate you giving your time on your free afternoon to come and talk with us.
Happy to do it.
Yeah.
So that being said, I think that's a wrap.
It's a wrap.
Thank you guys so much for tuning in. I guess we'll see you guys next time.
And shout out to UCSD Multimedia Services for their support. Thank you to UCSD School of Medicine for letting us use the space. If you don't know, now you know.